For many of us, taking regular medication is a familiar task. But before you took that pill or drove to the pharmacy, there are probably important steps taken with a doctor or another prescribing practitioner to ensure you receive the proper treatment. Hopefully that provides some clues about today's topic. You've probably guessed it, but we're covering the topic of prescribing. And yes, it is vast and wide, but there are some key aspects that every patient should understand. I guarantee you'll learn something new. You're listening to MedBoard Pulse, a podcast by the State Medical Board of Ohio. I'm your host, Jerica Stewart, Chief of Communications. Let's talk, Ohio. It's always a great feeling to be back in the studio and dive into a new topic. If you're new to the show, welcome and thank you for joining us. As I mentioned in the opening, today we'll be discussing prescribing. You may not be surprised to hear that the board handles prescribing cases on a regular basis because it's a very common aspect of healthcare. And because it's so pervasive, it's important for the board to create standards that safeguard the prescriber and the patient receiving the medication. Let's start with some basics. You will likely interact with several people when you visit an office, but not everyone in a clinical setting has the legal authority to prescribe medication, and that's a good thing. So who does? I'm glad you asked. Of course, doctors and podiatrists have the authority to prescribe. Physician assistants, which are also trained medical professionals, have prescriptive authority if they've completed certain educational requirements. There are also some providers the medical board does not regulate, including advanced practice registered nurses, like nurse practitioners, as well as dentists and veterinarians, although they are limited to treating animals. Of course, we'll be focused on the medical board's purview and how it regulates doctors and PAs. One of the most common prescribing problems we see as a board is the inappropriate use of medications known as controlled substances. Controlled substances have been categorized federally into 5 schedules based on the potential for abusive behavior, like forming an addiction. So Schedule 1 substances are considered to have the highest potential for abuse and cannot be used for medicinal purposes. The range continues in Schedule 2, Schedule 3, Schedule 4, all the way to Schedule 5, which are considered to have the lowest potential for abuse. Although the schedules are determined at a federal level, Ohio has specific rules that dictate the steps that providers must take to safely treat their patients when using a controlled substance. The board's rules surrounding controlled substances are located in Ohio Administrative Code 4731-11. If you explore this section of the Administrative Code, you'll notice that the chapter is organized by the types of medications. For instance, 4731-11-04 specifically outlines the rules board prescribers must follow when prescribing weight loss medication. 4731-11-08 calls out the board's prohibition against self-prescribing controlled substances and prescribing for members of your own family. It even specifically emphasizes that prescribers can't prescribe controlled substances to individuals in relation to whom a physician's personal or emotional involvement may render that physician unable to exercise detached professional judgment in reaching diagnostic or therapeutic decisions. In other words, it's hard to be objective when you're prescribing for a family member or a close friend. We see these cases from time to time. The board also provides very specific instructions for how to prescribe for pain management, which impacts so many Ohio patients. It may seem tedious to address specific topics and conditions through rules, but the factors involved when prescribing can be extremely complex. That's why it's essential that the person prescribing these drugs that can alter body chemistry and ultimately save lives or cause catastrophic damage be competent and well-trained. To help us understand some of the expectations of the medical board, I've invited one of our hearing examiners, Kim Lee, to sit down with me. Kim, thank you for joining me today.
Thank you very much.
Can you please start by introducing yourself and explaining your role at the medical board?
Yes, I am the Assistant Chief Hearing Examiner. I've been with the medical board for about 10 years now, 6 of them as a hearing examiner. And as a hearing examiner, it's our job to handle the board's hearings, and then we write reports and recommendations. I think it helps people if I describe what we are as we're kind of like judges. We conduct the hearings, we rule on motions and objections, we ensure the record is complete, and that the due process rights of respondents are respected. But unlike judges, we don't make the final decisions in cases. We make recommendations to the board members, and then they can choose to accept it or to make a different final decision in any case.
I think that judge analogy is really the most helpful thing for people to be able to kind of paint a picture.
I use it with pro se respondents all the time. And I'm like, hearings are like little mini informal trials.
Well, you kind of then answered my next question, which is you're presiding over these hearings and, again, listening to both sides of the story before the board makes that final decision. What is your goal during that process?
So the goal is to conduct a fair hearing, make sure that everybody is heard, and then come to a decision that is supported by the evidence.
The board is a complaint-driven agency, and I think there are sometimes concerns on both ends of either being overly punitive or also not taking action often enough, just depending on the audience. But the idea that we can't just, dish out discipline to our providers, we really are basing our decisions on the evidence that's presented. So I'm glad you pointed that out. So today, I appreciate you, again, painting the picture of a hearing examiner's role and also really describing some of the nuances of what's entailed. Today we're specifically talking about prescribing and the kind of issues that come to the board regarding prescribing. And I know from some personal experience that you actually give a prescribing presentation on a regular basis, a couple times a year, to help providers understand the board's requirements for safe prescribing. I imagine there's a lot to cover in that kind of training.
There is. It's an hour-long presentation I give that's part of a 3-day seminar, and I just give an hour of it, and it's focused on controlled substances in particular, so it doesn't cover every type of prescribing, but it's a push to get as much as I can covered in that hour, because there's so many facets to prescribing just controlled substances.
And that's why you're here today, because I feel like you are very used to talking about this topic, and I want to hear from you. I can't wait to learn more about this topic from you. But before we do, we're going to take a short break to hear from our favorite medical director for a Medical Minute segment. So we'll be back in a minute. Dr. O'Neill.
Good morning.
Good morning. You're back with me.
Yeah.
You just keep coming back.
I keep coming back every month.
So grateful. What topic are we discussing today?
Sure. I thought long and hard about what we should talk about today. And I really think we should spend a few minutes on exercise, because regular physical activity is one of the most important things people can do to improve their health.
Oh, no, you're going to guilt trip me today, aren't you?
Definitely.
So I will say, starting from when we were kids, in PE class, we're all told exercise is important. Get up and move. There was a whole campaign based on that. But on a practical level, what are the benefits of getting regular exercise?
Sure. Moving more and sitting less has tremendous benefits for everyone, regardless of your age, sex, race, ethnicity, or current fitness level. People with chronic disease and disability benefit from regular physical activity, as do women who are pregnant. Lack of physical activity is linked to approximately 117 billion. Can you believe it? 117 billion.
Billion with a B.
With a B. In annual health care costs, and about 10% of premature deaths. Significant. Childhood obesity rates have tripled since the 1970s, and obesity has disqualified about a third of Americans from serving in the military. Research has shown that health benefits start immediately after exercise, and even short episodes of physical activity are beneficial.
I guess my next question for you then is, how much exercise do we really need to get?
It really depends on age. And, if you have, preschool-age children out there, they really need to be physically active throughout the day. It improves their growth, it improves their endurance, and it improves their development. If you have, school-age children, recommendations are that they at least get 60 minutes of physical activity daily. Adults, we've always heard that 150 minutes per week. And that's, daunting to most people, saying, I can never do that. But research out there has shown that you no longer have to exercise, more than 10 minutes at a time for it to be beneficial. So short amounts of exercise are really helpful. And you need to start low and go slow. Work up to it. If you have a chronic disability, or you're older, or a woman who's pregnant, If you can do that 150 minutes a week, that's great. If you can't, start low, go slow. Talk to your healthcare provider about what you can and cannot do.
So start somewhere. That's what I'm hearing you say.
Correct.
Because I know that feeling of like, oh, I need to do this, but what's late until tomorrow? Tomorrow I'll get to it.
Don't wait till tomorrow. Start today.
All right. And I know the weather is starting to get nicer outside. Spring is here. You're really breaking out into something new. What are some of your favorite ways to exercise?
Well, I became involved in kickboxing several years ago. I know that's not for everyone, but for me, it's provided multiple benefits. Improved cardiovascular endurance. It's improved my balance and coordination. It's reduced my stress, which is paramount. And, it's improved my muscle and bone health. So, whatever activity you think you may want to do, try it. Go slow, start low, and work things up. You may find that kickboxing is for you or may not be for you. You may find that, walking, running, riding a bike, it all depends on you and your goals.
Awesome. Well, thank you so much. You've given us a lot to think about, and, I'll let you know tomorrow if I've
Remember,
put in some work today.
Start today.
Absolutely.
Don't wait till tomorrow. Have a great day.
Welcome back. Kim, we're talking about prescribing issues today, and I know it's an important topic both in healthcare and also in the news. I've also noticed the board regularly handles prescribing cases. Why do you think that is?
Well, the board has a bit over 100,000 licensees, the majority of whom are doctors or physician's assistants. And both of those licensees can prescribe medications. So just the majority of our licensees can prescribe. And then one of the most common activities that they do is prescribe medications to patients. And there's always a risk when you are prescribing to a patient. And these providers, your physician's assistants and your doctors, they have to keep a lot of things in mind when they're doing it. They have to consider whether to prescribe a medication in the first place, which medication to prescribe, how much to prescribe, how long should they prescribe for. They also have to keep in mind and consider what other medications the patient is taking to make sure there are no drug interactions. What other medications or comorbidities the patient has that would make one medication a better choice than another, or even if the patient has any allergies to medications or if they've just had an adverse reaction to some medication in the past. It is a lot of things to keep in mind, and it's a lot of points where a mistake can be made. And it's not just the decision-making issues that I've seen cases on. Our licensees have a duty to maintain complete and accurate records of their treatment of each patient. So I've seen cases with licensees who are just making poor medical decisions, and maybe that can be remedied with some extra training. Maybe it can't be remedied and their license is taken away. I've seen cases with providers who are intentionally issuing prescriptions for non-medical reasons, particularly when it comes to prescribing of narcotics and benzodiazepines. And sometimes I see physicians who could potentially have been providing good treatment for a patient, but their records are so poor that it is difficult to impossible to make the determination that they were providing good care.
So that does cover a wide range of areas of messing up, basically. It's a lot that can happen to get someone in trouble.
Yeah, and I like to emphasize in the presentation I give in the course that it's not just, bad doctors out there doing intentionally, bad things. It can be well-intentioned physicians who end up before the board with issues on prescribing.
In thinking about, again, all the categories you really listed, and that's not necessarily comprehensive, but really showing a lot of the kinds of issues that come before the board. That's so much to know and to understand about interactions with drug medications, or what even is the most I'm trying to think, what even is the most
Appropriate
or current, for that point in time, because medicine changes. How do prescribers even get trained and learn about those kinds of, those areas of things, to know how to prescribe and how to continue to be on, up to date and all of that?
Yeah, it's probably a little bit more difficult. It's probably a little more difficult for doctors than, say, attorneys like me, but we have similar ways to go about it. There's continuing education for doctors, and they're required to take so many hours every 2 years in Ohio. There's journal articles. It is their responsibility as licensees of the board and as practicing physicians or physician assistants in Ohio to keep up to date with modern medical practices.
What is the purpose of the board's prescribing regulations?
Our mission at the board is to protect and enhance the health and safety of the public through effective medical regulation. And I always emphasize the word effective there. And our prescribing regulations, our rules, are part of our effective medical regulation. Our board isn't out there just creating rules all willy-nilly to make life more difficult for doctors or to prevent patients from getting treatment that they think they need. Our goal is to protect the public. And one of the tools we have for that is creating regulations. In addition, I like to think that our rules and regulations actually help out our providers by giving them clear rules and boundaries within which to practice. The board has different regulations because there's different types of medications that simply need to be treated differently. So, for instance, controlled substances. We've got a couple general rules that encompass controlled substances as a whole, but then we have very specific rules. There's rules for Schedule II stimulants, like Adderall. There's particular rules for controlled substances for weight loss, like phentermine. And we've got very specific rules regarding the use of narcotics for acute, subacute, or chronic pain. There are different situations that require different regulation. So we have rules to cover those situations.
What are some of the common pitfalls prescribers fall into?
When it comes to prescribing, one of the common ways that I see well-intentioned physicians get in trouble with the board is by not keeping good medical records. A medical record needs to contain a lot of information, but essentially, another provider should be able to pick up that record and read it and understand immediately what condition was being treated, how it was being treated, how the patient was responding to that treatment, and why the original provider selected that treatment plan. No one should have to guess at what or why something happened in the treatment of a patient. Another common pitfall I see with prescribers is when it comes to prescribing controlled substances, is not even necessarily the prescribing of it, but not checking the ORS database at the intervals and time periods they are required to. ORS is the prescription management database for Ohio. It stands for the Ohio Automated RX Reporting System. It is run and managed by our friends over at the Board of Pharmacy.
Shout out to the Board of Pharmacy.
And it contains the information of all the controlled substances prescribed to a patient, as well as a couple other drugs like gabapentin. And it is an extremely useful tool for physicians because they can see what controlled substances a patient is getting and at what interval, so they can see if so they can see if a medication isn't being as refilled as often, or if maybe the patient is getting controlled substances from other providers that they weren't aware of. So it's a very useful tool for a multitude of reasons, and so the board has rules on how often it should be checked when prescribing controlled substances. And our doctors have to document in the chart that they checked ORs. Oftentimes, that's the problem. It's not that they aren't checking ORs, it's that they aren't documenting in the chart that it was done. And I have heard the board say over and over and over again in the 10 years I have been here, that is, if something is not documented, it was not done.
Thank you, Kim. This is some really interesting information and I think important for patients and caregivers. We're going to take a short break, but we'll be back to learn some more.
Following its monthly board meetings, the Medical Board posts a list of providers that have received citations for violating a board rule or law. This is called the monthly cite list. Anyone can view this list and see the providers that have received a notice of opportunity for hearing or a suspension that immediately takes effect. To view the cites issued each month, visit med.ohio.gov, click on the tab Laws and Regulations, and navigate to disciplinary information.
Hi, I'm Nate Turner, host of the Ohio Department of Developmental Disabilities podcast. If you are a loved one or interested in learning more about the developmental disabilities community, I invite you to visit dodd.ohio.gov/communication/podcast to check out our monthly podcast. You can also find us at SoundCloud, Spotify, and Apple if you search DODD Ohio Podcast. We cover everything from the impacts of technology, increasing independence, to the perspective of people with developmental disabilities, who, just like you, are trying to contribute to their workplaces, families, and communities. As I close every podcast, stay connected, stay informed, stay empowered.
Welcome back, listeners. Today we're discussing prescribing with our hearing examiner, Kim Lee. Kim, we frequently get asked about pain management and the rules surrounding opioid medications. Of course, most of us are very familiar with the devastation that's been caused by the opioid epidemic, and we felt the impact especially hard here in Ohio. Pain medications can be very addictive and dangerous if they are inappropriately prescribed. So the board adopted its current pain rules in the 2017-2018 time period. Can you tell me more about those rules?
Really, what the board wants to do with these rules is to let the physicians know that they should be looking at all options to treat pain. That includes non-opioid, non-medication therapy. But we recognize that in certain circumstances, opioids may be an appropriate course of treatment for people, and so we have these rules for the physicians to operate within. In general, the rules are split up by how long the pain is expected to last. So we've got a pain rule for what's called acute pain, and that's generally pain from like an injury that's expected to heal on its own in a couple of weeks. There's restrictions on that for the dose of opioids that can be given, the maximum dose, and even like the maximum number of days. It's very limited for pain that's just expected to heal on its own. Then we have subacute, which is pain that's expected to last a little bit longer but then go away. And then we have chronic pain, that's pain that can last months or even years. There are a lot of rules, particularly around the subacute and chronic pain that people will have, that physicians need to follow. For instance, the first thing that a physician should think of trying with the patient is not an opioid medication or a narcotic medication. The physician should always think about whether it would be most appropriate to try a non-opioid medication or some sort of alternative therapy, say like physical therapy or just rest. So after a doctor has considered whether or not a non-opioid or even a non-medication therapy wouldn't be appropriate, or maybe they've tried it and it just hasn't been successful, then they can consider whether or not an opioid or narcotic would be appropriate for any patient experiencing chronic pain. And There's certain steps that the doctor should do before prescribing to a patient. And generally, these include things like, doing a full history and physical on the patient. Determining the patient's ability to function in everyday life and how the pain affects their ability to function. And then if the physician decides to prescribe an opioid, they should always be prescribing for the minimum quantity of pills and at the minimum potency or dosage needed to treat the patient's pain. For instance, if a 5 milligram medication would work, then you don't want to start off with a 30 milligram medication.
That makes a lot of sense, especially considering the history of the abuse of these kinds of medications.
We do have rules that at certain what I call checkpoints in treatment, your treatment provider needs to essentially take a step back and evaluate their treatment and then make a decision whether or not to increase and continue or lower and continue or change the treatment plan or refer someone to physical therapy or some sort of maybe substance abuse counseling, depending on what the issue is. There are checkpoints where the providers need to take a step back, a breath, and evaluate the current plan.
So what are the types of things that our providers should be looking out for to make sure that they are not harming patients?
So when it comes to prescribing controlled substances, our providers, your physicians and your physician assistants, they always need to be on the lookout for red flags with patients. And that's how we, just refer to them as red flags. They can be as obvious as a patient having an overdose while they're being treated with a controlled substance prescribed by a physician. Or they can be a little more subtle. They can be patients asking for early refills on a regular basis. I've also seen it documented as a red flag when the patient is reporting losing prescriptions, be it they claim the prescriptions, and it's nearly always a narcotic or a benzodiazepine, was stolen, or they were in their, they had it sitting in their bathroom and they knocked it over and it went in a toilet. And I think the joke is always that I've never seen that happen with an antibiotic. It's always a narcotic or a benzodiazepine, and they need a refill right away. Other signs to look out for that we consider red flags are patients that are stealing medications from others, or they're sharing medications with others, borrowing medications. I'll borrow yours this month and I'll give you some of mine, when I get my refill, that sort of thing. Another red flag is just when a patient's taking more than prescribed. Say their prescription is to take 1 tablet every 6 hours, and they start taking 1 tablet every 3 hours, or 2 tablets every 6 hours. Some sort of change that increases the amount of the medication they're taking. It's a red flag. And I do want to emphasize, when I say red flag, it doesn't automatically mean that the patient is abusing the drugs in any way. Especially when it comes to things like narcotics or benzodiazepines or controlled substances in general, it could mean that the medication, that particular medication or the treatment plan, isn't right for that patient. So it could just be a red flag to reconsider the treatment plan. It could be a red flag of drug abuse. But the way I consider red flags is it's just something to pay attention to. This is something you need to look at and think about and address in some way.
And that becomes a problem when a licensed physician who should be, educated and trained is either ignoring those red flags or doesn't seem to notice.
Yes, I have seen well-intentioned physicians get in trouble with the board because they ignore red flags. They may keep great records. I've seen where they've documented the red flags over and over and over again with patients, but they do nothing with that information. And that is also a problem.
I think we've talked a lot about well-intentioned doctors, because I know we've said over and over again in this show that most Ohio physicians, and I can't speak for other states, I suppose, but I think across the board, people get into medicine because they want to help. Overall, physicians and PAs, or these licensed professionals, most are well-intentioned or trying to do the best they can, or sometimes they need more education, or they need to be brought up to speed on what is current in practice. But there also are people who are predatory in nature. There also are physicians who will blow past whatever safeguards or regulations are in place, and sometimes that's for financial gain or maybe reputation or whatever the case may be. Can we talk about that a little bit?
You're right. I do speak a lot about this, and I put the term well-intentioned in front of providers a lot, because most of our doctors and PAs are good people and just want to help their patients. There are those that maybe they started out that way and have strayed. There are doctors that will prescribe dangerous medications, narcotics, opioids, benzodiazepines, for what I would consider a non-medical purpose, mainly because they're getting paid for it. That's not only a violation of the board's rules and statutes, it's also a crime. I've also seen cases where doctors will be prescribing controlled substances and then threaten to withhold them unless they get what they want from the patient. That is not good medicine in any way, and it's, I'd say the most common way I've seen that is physicians who are withholding medication in exchange for some sort of sexual favor. That's just completely unacceptable and should never happen. So if you're concerned with something your physician has done, you can make a complaint to the board and we'll look into it. If you have questions about your treatment plan, if you think it's, bad, you can let the board know. But if you're just curious about why the doctor chose your treatment plan, you should ask your doctor. They should be able to answer those questions for you. If they refuse to answer, let us know so that we can look into it, because that's not providing good care to a patient, because the patient has to have a general understanding of the risks and benefits of their treatment plan. Even if you aren't the patient, if you have a family member or a friend who is the patient and you think that they're not being treated appropriately, or maybe you think they're being overprescribed medication, feel free to let us know and we'll still look into it. Just give us all the information you have, make a complaint with the medical board, and we can still investigate that. You don't have to be the patient to make a complaint to the board.
What do you like most about your job?
Our goal is to protect the public. That's it. It's that simple. We're here to serve the public. And my function at the medical board is to do that through hearings and my reports and recommendations. And honestly, I love getting in the nitty-gritty of these cases. I will pore over transcripts. I will go word by word through medical records, and I spend countless hours going through some of these records, and I really enjoy doing that. So I think it makes me particularly well suited to do this job.
I'm very grateful that you do your job, because I don't think I could do it. Thank you for taking the time to inform us about Ohio's rules when it comes to prescribing medications. I'm very grateful that you are willing to carve out some time this morning.
Anytime.
I hope that today you walk away with an appreciation for the expertise it takes to safely prescribe prescription drugs. Yes, there are regulations that address a variety of topics, but the purpose of the board's rules and laws are always to ensure that providers conduct safe practices. Remember, if you have a concern about a provider's prescribing practices or any other issue, you can file a complaint at med.ohio.gov. Thank you for listening to this episode of MedBoard Pulse from the State Medical Board. A special thanks to our guest, Kim Lee, hearing examiner, for explaining the board's rules regarding prescribing. Subscribe today to hear our episodes right away. For more information about the medical board, visit med.ohio.gov. You can also email questions or comments to communications@med.ohio.gov. And remember, the more you listen, the more you'll learn, the more you'll share.